My name is Kathrin LaFaver. I'm a neurologist in Saratoga Springs, New York, and I will be talking on behalf of Medscape today with Dr. Meredith Wicklund, who's a senior associate consultant and behavioral neurologist specialist at Mayo Clinic in Arizona. Welcome, Meredith.
Thank you.
So I'm very excited about our topic today. That we'll be talking about monoclonal antibody therapy against amyloid in Alzheimer's disease, which has been really a hot topic, especially this year with the FDA approval of Lecanemab and associated questions. Could you give us a brief overview why there has been so much research interest in this topic of anti-amyloid antibodies?
The pathological component of what defines something as Alzheimer's disease is, by definition, presence of amyloid plaques and tau tangles. And when it was first discovered in the 1980s that the component of the plaques was actually the amyloid protein, beta amyloid specifically, a lot of new interest went right from there in trying to develop therapies to directly target the pathology that is Alzheimer's disease.
So with Lecanemab now as the first FDA-approved disease-modifying antibody in that realm, could you review a little bit the study data, and especially as it applies to those of us in daily neurology clinic?
Well, the study data from the phase 3 trial did show on its primary outcome that there was a 27% slowing of decline compared to individuals on placebo. Now, it's important to point out that this was slowing of decline. It was not stabilizing decline. It was not improving decline. So I think it's important that we inform our patients that really, even with this therapy, there's no prospect of stabilizing and restoring cognition or function. But we do progress at a slower rate compared to individuals not on this treatment, which, given that this medication is for individuals in mild disease who have relatively preserved functional status, that can be potentially very meaningful to families. The overall benefit was small. It essentially amounts to half a point on an 18-point scale, which is statistically significant. How much clinical meaningfulness that actually leads to is unclear. And, defining clinical meaningfulness cannot be defined by a particular test. It really can only be defined on an individual patient level and what is meaningful to them.
It is my understanding that to qualify for lecanemab use, one needs to have a biomarker-supported diagnosis of Alzheimer's disease, either via like an amyloid PET scan or CSF biomarkers. What would your recommendation would be for a neurologist in practice to go about these requirements?
Since this medication is directly targeting the amyloid pathology and it does convey potential risk, we want to make sure that the actual pathology is present in the individuals before we treat them and potentially expose them to risk. The best way of doing that is through either an amyloid PET scan or spinal fluid testing of beta amyloid and tau. There are, in development, several plasma-based biomarkers. However, I would avoid using those currently. There's still a lot of unknowns in terms of what exactly is the right species of tau that we should be looking at, what's the right mechanism of the lab test, how does minority status influence it, how does different comorbidities influence it. So I would recommend at this time sticking with amyloid PET or CSF testing, given that amyloid PET is not widely available in many community practices, generally only available at academic centers, and is quite costly. Many insurances do not cover it, although Medicare has a proposal to potentially start covering it. I generally go with spinal fluid testing, which is a little more widely available. There are several labs across the country that can process that testing in a reliable way.
That's very helpful to know. And I know there's been a lot of buzz just these past couple of weeks about the blood biomarker sort of coming up. But I think it's, as you point out, this wasn't the markers used in the clinical studies, and there's still unknowns and to maybe not quite, unfortunately, time for its clinical use. Very good. We also have learned there are significant potential risks involved. And one issue specifically that's really been in the focus was this issue of ARIA, or amyloid-related imaging abnormalities. Could you speak a bit about that and requirements for monitoring and so on?
Yeah, so with ARIA, amyloid-related imaging abnormalities, that essentially amounts to either vasogenic edema or microhemorrhages or superficial siderosis that develop as a result of treatment, and it relates to disactivation of the immune system with these positive monoclonal antibodies that's going to occur with targeted against the plaques, and so in the parenchyma will cause edema, or if you have amyloid in the walls of the blood vessels, it can cause microhemorrhages. Now, while this name ARIA implies an imaging-related abnormality, and it largely is purely an imaging finding, it's not solely an imaging-related finding. It can cause symptoms, including very serious symptoms. Overall, with lecanemab, the incidence of ARIA within the treatment group in the phase 3 study was combined between both ARIA-E and ARIA-H was 21.5%, with about 17% being ARIA-H and about 12.5% being ARIA-E. And of course, they can occur at the same time. Now, overall, in terms of people in the clinical trials that about 3% developed symptomatic ARIA. Most individuals, it purely was imaging-related finding, but not all individuals, 3%, did have symptoms. And some of those are very serious symptoms, including things like seizures, need to be hospitalized, and a couple of deaths been attributed to ARIA as well.
Right, and I guess along those lines, what any additional words to say for people who might be on anticoagulation or might require treatment for medications for a stroke, for example?
While individuals on anticoagulation were allowed in the clinical trials, the current published appropriate use guidelines is recommending against its use, as several of the serious adverse effects, including the deaths, were for most part attributed to anticoagulation use. When it comes to acute stroke treatment, one must carefully consider use of TPA, as 2 of the 3 deaths were TPA associated in the clinical trials. It shouldn't necessarily be an absolute contraindication, but it can make the clinical picture very muddy. If an individual is on lecanemab and comes to the ER with acute stroke-like symptoms, it's more likely that they're going to be having an ARIA, a side effect, rather than an acute stroke. A general recommendation would be to obtain an acute head CT with a CTA, and if there's a large vessel occlusion, proceeding to thrombectomy. However, if there isn't a large vessel occlusion, if you have the ability to get a rapid MRI to screen for DWI with acute stroke changes or tissue flare with acute edema changes suggestive of ARIA, that would be preferred before proceeding with thrombolysis, though these are all relative contraindications and are going to depend on what's available near you.
Got it. And it's definitely an issue because the population we're talking about is definitely at risk for
Absolutely.
as well as Alzheimer's disease. Yeah. So where do you see this field going as far as amyloid antibody therapy is concerned, with like another agent, donanemab, possibly getting FDA approval later this year as well?
Yeah, we're anticipating that donanemab will get FDA approval in the next coming months. Donanemab also targets the amyloid in the brain, although lecanemab and donanemab do target different aspects of the production of the amyloid plaque. They were both shown to have roughly equal efficacy in their phase 3 clinical trials. And donanemab has one benefit of being once monthly infusion as opposed to twice monthly infusions with lecanemab. It does have a slight higher risk of ARIA compared to lecanemab. So those are just considerations you'll need to take into consideration in talking with your patients. In terms of where we're going from here, well, we're moving even earlier in terms of disease state. Lecanemab, donanemab, those phase 3 trials were done in individuals with either MCI or mild dementia due to Alzheimer's disease. They should not be used in individuals with moderate or more advanced Alzheimer's disease. So our ongoing large clinical national multi-center clinical trials of both lecanemab and donanemab in a preclinical state of Alzheimer's disease. So individuals who have evidence of amyloidosis, either through PET imaging or through CSF, but yet are clinically asymptomatic, do not have any signs of cognitive impairment or functional decline. And so we look forward to those results the next few years. And hopefully they'll be able to show even greater benefit when moving into these early disease states in terms of at least hopefully maybe delaying or even preventing cognitive decline.
It's definitely very interesting to hear about. Yeah. So where can people go for more information?
Well, there's guidelines on the use of lecanemab through the American Academy of Neurology, so I encourage you to look at that. Also look at the appropriate use recommendations that were published this year in the Journal of Prevention of Alzheimer's Disease.
Wonderful. And we'll link that in the notes. So with that being said, thank you so much for talking to me on behalf of Medscape. Thanks everyone for listening, and I'm sure I learned a lot. Thanks so much.